Hello everyone, and welcome to my video on ECG interpretation. Now, when I first had a look at an ECG when I was a nursing student, my first reaction was, well, that's a load of squiggly lines, I'm never going to learn that, I don't need to know that, it's a doctor's job. And I hear this too often from many student nurses, but simply, you do need to know it. Yes, doctors have a bigger role to play in ECG interpretation, but as a nurse, even as a student nurse, you need to be aware of any urgent changes in an ECG so you can inform the doctor as soon as possible, because rapid care is really important and can make the difference between saving your patient's life or not. So please don't dismiss them. They are made out to be very complicated by the textbooks and the literature out there. They're really not that complicated if you break them down slowly and in little pieces and follow a structured method to interpreting them. So I'm going to try and make that as easy as possible for you. If I do miss anything or you're unsure of anything, then please do ask questions either on the messages below this post, or you can send me a private message. But here we go. So as I said, you've got to have a structured approach. There's many different ways, many different methods to interpreting an ECG. And I'm just going to tell you the way that I interpret them. So first of all, you need to be looking at the rhythm strip here. Don't get tangled up in all this confusion. We're focusing on this. Now on this ECG, this is lead V1 for some reason, that's the rhythm strip. Usually you will find lead 2 to be the rhythm strip, because that sits over the left ventricle and it's the most accurate view of the left ventricle. I'm not sure why V1 was used here, but it doesn't matter. We can still use this for interpretation purposes for this tutorial. Okay, so the 5-step method that I use is number 1, you calculate the rate. Okay, so we're focusing on this here and we're going to work out the rate. Now there's lots of different ways to calculate the rate of the ECG strip, and it's up to you, whatever you feel comfortable using. If you know your own way to calculate the rate, then use that. There's no one that's better than the other really. The easiest way to do it is calculate the number of R waves, which are here. Remember, so we've got P, Q, R, S. So here's our R waves. We count the number of R waves across the whole rhythm strip and we'll multiply that by 6. Because this is 10 seconds long, this whole strip here. Okay, so we want to work out the number in a minute. We'll multiply the number of R waves by 6. There's 16 R waves, which gives us a rate of about 96 beats per minute. And once you've had a look at a lot of ECGs, you do get a feel for roughly how fast they are just by looking at them. It just comes with experience. Okay, so now we've calculated our rate. Now we need to work out our rhythm. Is it regular? Is it irregular? The easiest way to do this is to just grab a piece of plain A4 paper, line it up against 3 R waves and just mark them off on your paper. Move the paper across to the next lot of R waves. Do they line up? If they do, great, you're regular. If not, you're irregular. And just keep doing that along the ECG so you can find out whether you're regular or irregular. Number 3 is to measure your PR interval. The normal PR interval is 3 to 5 small squares, and each small square measures 0.04 of a second. So 3 of those is basically 0.04 times 3. 4 times 3 is 12. So that works out to be 0.12 to 0.2 seconds. These questions often come up on exams. Now, if If the PR interval is longer than 5 small squares, it means there's some degree of heart block there. And that's a whole other new tutorial about different types of heart block. We can have a look here from the start of the P wave to the R wave. I can see straight away that that's more than 5 seconds, so there's some degree of heart block here, which would tie in with this whole ECG. Okay, so we've established that the PR interval is too long in this rhythm strip. Then we look at the QRS complex. Okay, so remember the QRS complex is the ventricles depolarizing. Now we need to make sure, here's our Q wave. We've got to count the small squares. I know it's hard to look at on the screen, but I know that that's less than 3 small squares. So we've made sure that it's less than 3 small squares. If it's more than 3 small squares, then it means there's some ventricular problems, which could be a left bundle branch block or a right bundle branch block. Don't get too confused with this terminology. We can save that for another video on ECG interpretation. Okay. Now the big one, number 5, we're looking at the ST segment. So we've had this patient coming in with 10 out of 10 crushing chest pain. We want to identify if they've had a cardiac event or not. Are they having a STEMI or a non-STEMI? Let's have a look. This is how we find out. We have a look at our ST segment. Okay. So remember, we've got our P wave, Q, R, S. And then there's our T wave here. Okay. Now, the way to have a look at this closely is to measure our isoelectric line, which goes along here. Now, if you can have a look at the start of the S wave, is it above or below the isoelectric line? It's above. It's up here, isn't it? And it should be here. So if it's above the isoelectric line, this would be ST segment elevation, because it's above, it's elevated. Okay. If this was below the isoelectric line, it would be ST depression, because it's depressed, it's sad, it's below the isoelectric line where it should be. Okay. And that we would call a non-STEMI. Simple, hey? Alright, now we've established that, we can have a look and we can see that, you know, we've got some degree of heart block and we've got a STEMI in this ECG. Now we need to interpret what's going on. This is where we come to all these little bits, all these leads. These are your 12 leads which form up your ECG. Now you need to familiarise yourself with what areas of the heart these leads are referring to. And the only way you're going to do that is with some practice. You need to have a look. So we've got lead 2, 3, AVF. These 3 leads here, these group together and these look at the inferior aspect of your heart. Good way to remember this is that looks like an I, and there's an F there. And there's I and F in inferior. Okay? So these are grouped together. The other common area where you can have infarcts is your anterior aspect of your heart, which is V1, V2, V3, V4. Okay, so these 4 leads. And remember, these sit on the anterior chest wall, and the infarct would be basically directly where those leads are sitting. Okay, so V1, V2, V3, V4, they're all grouped together, and that's the anterior aspect of your heart. So if you saw some ST elevation in these 3 leads, which is the inferior aspect of your heart, you would be having an inferior STEMI. Okay, so now we have a little bit of a closer look at these leads, and you can see there's the isoelectric line, and it's obvious the ST segment is way up here when it should be down here. And it's the same in lead 3, the same in lead 2, and the same in AVF. So we know that we've got an inferior STEMI. Don't get sucked into this here. There's a bit of ST elevation there. There's a bit of ST depression here. These are just reciprocal changes, okay? This is not, it's not something you should focus on, because when we look at lead V2, V3, and V4, you see they're fine, okay? So focus on what's showing here. So we've got ST elevation here. Where is the ST elevation? It's in your inferior leads, 2, 3, AVF. So the interpretation of this ECG is an inferior STEMI. So top tips, look at the rhythm strip at the bottom to determine all of the above before being sucked into the rest of the ECG. So you want to be looking at your rhythm strip, which is usually lead 2 here. Okay. Practice, 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 because we all know this means perfect. You can just type in inferior STEMI, anterior STEMI into Google Images, and it'll bring up loads of ECGs for you. Lifeinthefastlane.com is also a really, really good resource with a massive ECG library. Another top tip is to always make sure that lead AVR, this is the one lead that's always negative. Okay? If this is positive, it means that either the leads have been switched up, which happens really commonly. People switch from right to the left leg by mistake because we're in a rush because our patient's got chest pain and we're under the pump. And that can actually skew the results of an ECG, which is really why it's important to check this lead. Another reason this lead can be positive is if a patient has dextrocardia, which means the heart sits on the right side as opposed to the left side of the body. Okay, I hope that helped. I think I've babbled on for a bit longer than what I normally should, but I hope that gives you a bit of an insight into ECG interpretation. And I will post another one. If you let me know what you'd like, would you like an anterior STEMI and a non-STEMI? Just let me know and I'll do another video with another ECG interpretation for you. Happy studying, guys. Thanks.